And well, I think that we have a different tone for the discussion today compared to yesterday. Okay, dengue is still a tragedy, but hopefully we get some good news right now. Well, you should know that very likely I'm biased on this presentation based on two main reasons. First, I'm from Brazil and dengue, and you're gonna see why I'm biased in a few minutes. And again, I'm from Brazil, and we have one of the most amazing immunization programs in the world. And I'm somewhat spoiled by it. Okay, this partnership between dengue virus and Aedes mosquitoes, they're taking quite a beat on us. We have very limited success in prevention activities, despite huge efforts from local, national governments. A lot of work here and very few results so far. And dengue prevention has been mainly focused on the vector control. And even for vector control, we lack new insecticides and we have an increasing resistance to the existing ones. Well, when you think about dengue and its trends, dengue in the Americas region, it's quite impressive. Since the 80s, the number of reported cases for each decade, it has been showing a twofold increase by decade. We moved from 1.5 million in the 80s to 3 million in the 90s to almost 7 million in the 2000s. And by early 2015, and I mean early, January, we already had more cases in this decade than the decade before. So likely we'll double it again. It's very likely that we'll be reaching 14 million, maybe 15 million cases this decade. And most of it is driven by Brazil. We have a very similar scenario. We have been large outbreaks and mainly reflecting the shift in the predominant serotype over time. So we have these cycles of different serotypes with larger and larger epidemics. And yesterday, Tiki and I, we were discussing some of these numbers and he was impressed with our numbers. Okay, for the last 6 years, we had more than 1 million cases in 4 of them. It seems that 1 million cases annually, it's our baseline for now. And let's talk about disruption. Weeks with more than 100,000 cases reported. 9, 10 consecutive weeks. This is what we can show as a disruption in the system. For Zika, we were quite able to absorb most of its impact because we have a fairly well-established health system in Brazil. But this is something else. We're talking about 100,000 people reported with dengue on consecutive weeks. And if you take any of these, 2 of these weeks, they had more cases than the entire year of 2004 in Brazil. Okay, when I think about a dengue vaccine, what do I want? Obviously, I am and we all are public health officers. So what do we want? We have a very simple answer for that. I want it all. I want long-term protection, high efficacy and effectiveness, cost effectiveness. It should be affordable, protective against each of the 4 serotypes, not only safe, but super safe, and easy to implement. Okay, and now we have a vaccine available after decades of research, and at least from more than 20 years for Sanofi. And now we have these results. And in general, we have seen a combined efficacy for symptomatic disease of 65%, reduction of hospitalizations of 80%, and a reduction of severe disease higher than 90%. Well, there has been a lot of discussion on these numbers, but basically a lot of people were focusing on this. But this is really, really good for us. And as Brad mentioned on the first day, even if you have an intermediary efficacy, we have a huge disease burden. So we can still have a lot of impact even with this scenario. Okay, since last December 2015, the vaccine was licensed in Brazil. So at that time, our regulatory agency licensed the vaccine for its use for people between 9 and 45 years of age. So I was very interested in understanding this profile in our setting. Okay, 9 to 45 in red here, they had the higher incidence in Brazil over time, over the past 17 years. And when you look at the proportion of cases, remember that basically we are talking about 10 million probable dengue cases here. And almost 70% of them, they were included in this age group from 9 to 45. And not only from 9 to 45, they're quite well distributed among different age groups within that range for probable cases, but also for hospitalized cases over time. So basically for both probable and hospitalizations, between 60 and 70% of the cases are there. Well, but other countries, they also have similar patterns, like Mexico, for instance. Most of the cases in young adults. In other countries, we have seen some variations, like Venezuela with more cases among children, Colombia with a little more balanced. But again, we can see a lot of cases in this age group. Okay, and now we have the WHO position that the vaccine should consider in geographic settings where we have high burden of disease. And to maximize the health impact and cost effectiveness, they have a target for seroprevalences higher than 70%, and at least 50% of seroprevalence in the target age group. And we'll get to why we have this recommendation in a couple of minutes. But how is seroprevalence at 9 years of age with some of the available data that we have so far? Well, baseline seropositivity for the studies in Latin America and Asia for Sanofi trials, they showed seroprevalence varying from 48% in Mexico up to 91% in Colombia. Other studies of seroprevalences have found at the age of 9 results ranging from 40 to 81%. And we're talking about some areas in Brazil, Thailand, Mexico, and India. And right now we have an ongoing initiative by the Brazilian Ministry of Health. We have a study being conducted. Most of the field work has already, it's completed. We're just waiting for the results at this point of serosurvey studies in over 70 different cities in Brazil. So this is part of this previous effort to try to better understand the dynamics of dengue and to prepare for the introduction of a vaccine that our MOH has been working on with other initiatives like DVI, PDVI over time. But this also sets a very interesting scenario for modelers. So Ira, if you are interested in this, we can estimate seroprevalence using surveillance data, mortality data, and other data. And it would be really nice to have these estimatives prior to the results of these studies. Because if we do it after that, they're going to say that we tweaked the model to reach its results. So if you are interested in that, we have all the data available. Well, after Sanofi results, WHO organized a very interesting initiative to bring on several different modeling groups. And based on the results, especially, the main concern was the higher hospitalization rate in the third year of follow-up in the age group of 5 and below. So basically, we have three different scenarios. We have unvaccinated, that they have a primary infection, a higher risk of severe disease in the secondary infection, and most of the post-secondary infections, they would be of low risk. For the vaccinated group, the first infection would play a different scenario if no previous infection was observed. This is a potential scenario that the vaccine could lead to a secondary-like response with a higher risk of disease in vaccinated people that were naive before. And vaccinated people with previous infection, they should be free of risk for a severe disease. But again, this is all based on what we have of data so far, and they have seen this higher hospitalization rates in the third year, but it has gone away in the fourth year, apparently. So we need to follow these up to better understand what happened. But okay, so WHO invited a lot of different modeling groups to try to show the impact of the vaccine introduction in different scenarios. And basically, all the models agree that if you have a seroprevalence at the age of 9 of 50% or higher, the results are all pretty good over time. And if I say something stupid, Ira, please correct me, because I'm not a modeler. And basically, we see it for everyone, especially above 50%. But not only for symptomatic dengue infections, but also for hospitalizations. So we have this really interesting scenario, about 50% of seroprevalence at the age of 9. And mainly, this is what supported WHO's recommendation at this point. But they also worked on some results for the whole cohort, the seronegatives and the seropositives impact. And some of the modeling showed that even with seroprevalences higher than 50% for symptomatic dengue, we basically see good impact, but some of them showed some risk of higher hospitalization for the vaccine seronegatives at this point. But again, it's based on what we have seen so far. And we need to better understand it over time. So basically, all models predicted that in settings with moderate to high dengue endemicity, the default vaccination policy would reduce the burden of dengue. And again, those results were based on routine vaccination of 9 years of age. If we had catch-up, the higher the number of cohorts vaccinated, the higher the impact, basically, that we would see. And in settings with low transmission intensity, the models predicted that vaccination could lead to a substantial increase in hospitalizations because of dengue. Well, Brett gave us an impressive lecture on the first day, and basically he had also bring that concept here. So now it's Annelie's turn to tell me that, okay, you're saying something stupid if I do it, but hopefully I won't. Well, when we look at Latin American region, we see the results that we have discussed so far. 65% of efficacy for virologic confirmed dengue, 80% for hospitalizations, and 96% for severe disease. And when we look at the vaccine preventable disease incidence, the higher is the better. Even for the 65% of efficacy, we could reach almost 1,800 cases prevented for each 100,000 vaccinated people here in our region. Sorry, our means American region, and we're in Europe right now, and in Latin American region. And the number needed to vaccine again, basically we need to vaccine 28 people to prevent one case. So these results are very, very interesting and even higher than what we have seen with some other vaccines. In this paper, they also mentioned that even for seronegatives, the results are quite impressive, but they also state that safety wasn't one of the things that they took into account because they were working with the results for the first 2 years of follow-up. So based on these results, we show high efficacy against severe clinical dengue. The dengue VPDI is very high, almost more than 1,700. The dengue NNV is very low, 28 people, as I mentioned. And in addition, analysis found that the vaccine has favorable VPDI and NNV when compared to other vaccines that are already in use, like Hib, rotavirus, PCV. And remember that what we want it all. We want the best of vaccines like Hep B. We also want the wonderful surprises that we saw with rotavirus. We want it all, but we still don't have all the answers at this point. But the vaccine showed to prevent severe clinical illness, to reduce the utilization of health services, and reduction in overall disease burden. And when we think about the burden of the disease, we have these amazing direct costs that some of these studies have shown, and even higher indirect costs due to dengue in endemic areas. So finally, I think that, okay, WHO recommends the introduction of the vaccine in highly endemic areas. But the baseline is the countries that are endemic, most of them, they are really high endemic for dengue, like Brazil, Colombia, Venezuela, and the Americans, and a lot of different countries in Southeast Asia. And the negative impact of the entire population can be avoided by choosing the target age for vaccination, in which seroprevalence exceeds 50%, but for other groups, it could be even as low as 35%. Understanding any differences between naturally and vaccine-acquired immunity will be critical for us in assessing the overall impact of disease in this group, and to maximize the population impact of vaccination and to prevent negative impacts. It would be necessarily to careful tailored vaccination strategies to local epidemiological conditions. And if available, population serosurveys or even individual data can mitigate risks in planning routine vaccination. We want it all. I would like a vaccine that we could use in the army, we could use for travelers. But by the end of the day, most of the people suffering from dengue, they live in highly endemic areas. And we're talking about millions and millions of cases every year. So we really need something different. And I truly believe that at this point, we have an opportunity to finally move ahead. And even if we play the safeguard here, okay, let's start with the highly endemic areas with seroprevalence is higher than 50%. We all seem to agree with that, at least with that at this point. But in the future, we can even have some different perspectives after the introduction of the vaccine in a larger scale. Thank you.